data from the CDC-funded National HIV Behavioral Surveillance Study, which we do in Denver with populations of men who have sex with men every 3 years. Do them in 3-year cycles. I'm presenting data from the years 2008, 2011, and 2014. And this is our surveys, detailed surveys based on demographics and risk factors for HIV in our urban metro setting. Well, PrEP is really our newest and best biomedical prevention strategy, which means it's a pill that has to be prescribed and taken, which means that someone who wants to be on PrEP for HIV prevention has to get into our healthcare system, or they have to be recruited by someone from within the public health system or from healthcare. And so there's this new opportunity and challenge for getting a patient-provider connection going for PrEP. This is a study that's done nationally, and there are paid recruiters that go out and recruit men who have sex with men from various venues where they are known to frequent. And so the survey methodology is actually really detailed, where paid recruiters go and ask a series of questions that take almost an hour to administer. They're very detailed, and they're based on previous experience. And they also offer things like free on-site HIV testing and a lot of counseling on-site. One of the most important questions is whether someone who starts PrEP will engage in riskier sexual behavior as a result of being on PrEP because of the relative safety they feel being on this medication. And that's something we call risk compensation. And that's a controversial subject. Most of the literature to date has not shown that to be the case, although most of the literature to date is focusing on clinical studies where it was sort of a non-realistic treatment environment where people are coming in for lots of counseling with big emphasis on condom use and other forms of prevention that have traditionally been part of the HIV prevention armamentarium. So in those studies, we have not seen any evidence of risk compensation. However, there is some evidence coming out that shows that this may be the case. In other words, there may be more other sexually transmitted infections coming about as a result of being on PrEP. We're concerned about other sexually transmitted infections, and specifically we're interested in syphilis, gonorrhea, and chlamydia. Those are the big ones. And the real concern is, will people who go on PrEP be more likely to get those as a result of changes in sexual behavior? So as a family practice physician, I'm really interested in the intersection of PrEP for HIV prevention and primary care. And I really think that primary care is where PrEP needs to start for a lot of people, because so many of our patients who are starting PrEP have other needs. People may be on PrEP for a few months and then go off of PrEP. They may not need it anymore, but the other primary care needs they had when they came into the system will still be there. A lot of them have complicated social situations, other healthcare problems, and of course substance abuse also is a big concern. Those are problems that don't go away even when someone decides not to go on PrEP anymore, and that's the reason we think they should still be in primary care.